The fluorescent lights of St. Michael's emergency department buzzed with a frequency that made Dr. Ethan Cole's jaw tighten involuntarily. 28 years old, brilliant beyond measure, and burdened with a mind that processed every sound, every flicker, every scent with overwhelming intensity, Ethan stood at the nurse's station reviewing lab results when the automatic doors burst open with a pneumatic hiss that sent a shiver down his spine. Paramedics rushed in with a gurney, carrying a man in his mid-50s, his tailored charcoal suit soaked with sweat, his silk tie loosened and askew, his face twisted in an agony that transcended mere physical pain. The man's skin had taken on a yellowish hue that immediately caught Ethan's attention, triggering a cascade of differential diagnoses in his mind, like dominoes falling in rapid succession. Severe abdominal pain, persistent vomiting, acute confusion, onset approximately 30 minutes ago, one paramedic shouted as they wheeled him past, the gurney's wheels squeaking against the polished linoleum floor in a rhythm that Ethan's brain automatically catalogued and tried to predict. Ethan's dark eyes locked onto the patient with laser focus, absorbing every detail. The yellowed sclera barely visible beneath fluttering eyelids, the slight tremor in hands that suggested hepatic encephalopathy, the way his breathing came in shallow, desperate gasps indicating possible metabolic acidosis, the faint smell of something sweet and sickly that others wouldn't notice but that Ethan's heightened senses identified immediately as the characteristic odor of liver failure. Something was catastrophically wrong with this patient, and every cell in Ethan's body, every synapse firing in his extraordinary brain, knew it with absolute certainty. But before he could step forward to begin his assessment, Dr. Richard Thornton, the senior attending physician with silver hair perfectly styled, and an ego to match his reputation, intercepted the gurney with the supreme confidence of a man who'd never been wrong in his life, or at least never admitted to being wrong. "I've got this one, Cole," Thornton said without even glancing at Ethan, his voice carrying that dismissive tone that had become achingly familiar over Ethan's 3 years of residency. "Why don't you go check on the sprained ankle in room 4? Maybe do a wound irrigation in 6, something more your speed." The dismissal stung with the precision of a scalpel, but Ethan was used to it by now, had built up layers of scar tissue over the raw wounds that such casual cruelty inflicted. He watched silently as Thornton began barking orders with theatrical authority, calling for pain management and a basic metabolic panel, treating the emergency like a routine case of gastroenteritis or perhaps acute pancreatitis, nothing that required the full mobilization of the trauma team. But Ethan's mind was already racing ahead, pattern matching against thousands of cases he'd memorized from medical journals, textbooks, and his own photographic memory of every patient he'd ever encountered. The yellow tinge to the skin combined with the confusion, the abdominal pain localized to the right upper quadrant based on how the patient was guarding that area, the respiratory distress suggesting possible hepatopulmonary syndrome. His brain assembled the pieces like a three-dimensional puzzle, spinning in his mental vision, each symptom a building block in a structure that was becoming increasingly clear and increasingly terrifying. This wasn't routine. This wasn't a case that could wait for labs to come back and committee discussions to determine treatment. This was critical. This was urgent. This was a man balanced on the knife's edge between life and death. And time, that most precious and unforgiving resource, was running out with every labored breath the patient took. The patient's name was Marcus Whitfield, and within minutes of his arrival, the entire emergency room knew exactly who he was, whispers spreading through the department like ripples across water. "That's the Marcus Whitfield," one nurse named Jennifer whispered urgently to another as they prepped the trauma bay with practiced efficiency, hanging IV bags and preparing medication drawers. "The defense attorney, he's defended half the politicians in the state," My husband saw him on court. TV last month absolutely destroyed the prosecution's case in the Henderson corruption trial. Another nurse, an older woman named Patricia, who'd worked at St. Michael's for 23 years and had seen every kind of patient imaginable, nodded with wide eyes that betrayed her starstruck nervousness. I saw him on the news just last week. He got that real estate developer acquitted of fraud charges, even though everyone knew the guy was guilty as sin. They say Whitfield charges $5,000 an hour and has a vacation home in the Hamptons. Never thought I'd see him on a gurney in our ER. Ethan absorbed this information peripherally, the way his brain automatically processed and categorized everything in his environment, even when his conscious focus was elsewhere. But his primary attention remained fixed on the medical mystery unfolding before him. Marcus Whitfield lay on the gurney looking diminished, despite his expensive trappings, his $1,000 watch glinting under the harsh overhead lights, his Italian leather shoes still perfectly polished, even as his body failed him. His breathing had become more labored in just the few minutes since arrival, a subtle but significant change that Ethan noted with growing alarm. Dr. Thornton stood over him with the calm assurance of someone who'd handled 1,000 similar cases, his body language radiating control and competence for the benefit of the watching staff. "Mr. Whitfield, I'm Dr. Richard Thornton, Senior Attending Physician. You're in excellent hands here at St. Michael's. We're going to get you stabilized and figure out exactly what's causing this discomfort." But Marcus's eyes were unfocused, his pupils slightly unequal in size, anisocoria suggesting increased intracranial pressure, possibly from cerebral edema, and his words came out slurred and disconnected. "My stomach feels like it's on fire, like someone's can't think straight. Where am I again?" Ethan stepped closer, his fingers drumming against his thigh in a rapid, repetitive pattern, a self-stimulating behavior that helped him think through the overwhelming sensory input that gave his hands something to do while his mind raced through diagnostic trees. He studied Marcus's face with the intensity of someone reading a book written in a language only he could fully comprehend, noting the slight asymmetry in his pupils that confirmed his initial observation, the way his skin had taken on not just a yellow hue, but an almost greenish undertone that suggested not just hyperbilirubinemia, but possibly cholestasis, the fine tremor in his hands that could indicate asterixis, the flapping tremor characteristic of hepatic encephalopathy. His mind flashed through differential diagnoses like shuffling cards, acute viral hepatitis, alcoholic cirrhosis with acute decompensation, bile duct obstruction from cholelithiasis or malignancy, acute liver failure from toxin, exposure or medication, Budd-Chiari syndrome, autoimmune hepatitis with fulminant presentation. Each diagnosis carried different implications, different treatments, different prognoses. Then Thornton noticed him standing there, noticed the way Ethan was studying the patient with that unsettling intensity that made people uncomfortable. "Dr. Cole, I believe I already gave you an assignment. Room 4 is still waiting. The sprained ankle?" Remember, Ethan's voice emerged quiet but firm, with that characteristic flat affect that people always misinterpreted as coldness or lack of emotion, when in reality it was simply how his brain processed speech. "His liver is failing. Acute hepatic insufficiency with progression to encephalopathy. We need to check ammonia levels immediately and get imaging of the hepatobiliary system." Thornton's expression hardened, his jaw clenching in a way that broadcast his irritation to everyone in the room, except possibly Ethan, who struggled to read such subtle social cues. "Thank you for your input, Dr. Cole, but I'll make that determination when the laboratory results come back. I've been practicing emergency medicine for 23 years. I think I can recognize liver failure when I see it." Marcus Whitfield's consciousness flickered like a dying fluorescent bulb, moments of clarity punctuated by growing periods of confusion and disorientation. Through the thickening fog of pain and cognitive impairment, he heard voices, crisp, authoritative tones giving orders, the mechanical beep of monitors tracking his vital signs, the shuffle of feet on linoleum, the rustle of sterile packaging being torn open. His entire career, spanning 3 decades of courtroom victories, had been built on reading people with surgical precision, on sensing weakness in witnesses and exploiting it without mercy, on commanding a jury's attention with the same iron will he now desperately tried to apply to his own failing body. But his body, for perhaps the first time in his adult life, wasn't listening to his commands, wasn't responding to sheer force of will. The pain in his abdomen had evolved over the past 72 hours from a dull, ignorable ache that he'd attributed to stress and too many business dinners, to a consuming inferno that made every breath feel like swallowing broken glass, every movement an exercise in agony. He'd ignored the early symptoms with the arrogance of someone who'd never been seriously ill, who'd always been able to power through discomfort through sheer determination, the profound fatigue that made climbing stairs feel like mountaineering, the complete loss of appetite that had him skipping meals for the first time in his life, the slight yellowing of his skin that he'd noticed in the bathroom mirror 3 days ago, and attributed to bad lighting or maybe the lingering effects of that experimental supplement his personal trainer had recommended. Marcus Whitfield didn't have time to be sick, didn't have space in his meticulously scheduled life for weakness or vulnerability. He had 3 major cases going to trial within the next month, each one worth millions in fees. He had depositions scheduled, strategy sessions with his legal team, a keynote speech at the State Bar Association conference. Now, as gloved hands pressed against his abdomen and he heard himself groan involuntarily, a sound of weakness that he would never have permitted in a courtroom, he realized with dawning horror that his arrogance, his refusal to acknowledge his own mortality, might have cost him everything. "We're going to give you something for the pain, Mr. Whitfield," Dr. Thornton said, his voice smooth and reassuring, carrying that practiced bedside manner that Marcus recognized from his own courtroom performances. "Just a little morphine to make you comfortable while we run some tests and figure out what's going on." But there was another voice, younger, with an unusual cadence that Marcus's lawyer-trained brain immediately catalogued as different, as outside the normal range of social communication. The voice lacked the melodic variation that people unconsciously used to convey empathy, lacked the social lubrication that smoothed interactions. "Dr. Thornton, we should check his ammonia levels immediately and get a CT scan of his abdomen with contrast. The confusion combined with the jaundice and ascites suggests hepatic encephalopathy, possibly from acute liver failure or acute on chronic decompensation. This is critical. We're looking at a potential fatality within hours if we don't identify and address the underlying cause." Marcus forced his eyes to focus, fighting through the mental fog that seemed to be thickening by the minute. The young doctor who'd spoken stood slightly apart from the others, his posture rigid and uncomfortable, his hands moving in small, repetitive patterns. Against his thighs, his eyes not quite meeting anyone's direct gaze, but instead seeming to focus on a point just past people's shoulders or on objects in the room. There was something distinctly odd about him, something that Marcus's predatory instincts, honed by years of cross-examining witnesses and identifying people's weaknesses, immediately flagged as exploitable, as different, as other. Who is that?" Marcus managed to ask through the pain and confusion, his words slurring together. Dr. Thornton glanced dismissively at the younger doctor with barely concealed irritation. "That's Dr. Cole, one of our residents. Don't worry about him, Mr. Whitfield. You're under my direct care. I'm the senior attending physician, and I assure you that you're receiving the absolute best treatment this hospital can provide." Ethan Cole's medical school professors at Johns Hopkins had told him repeatedly, with increasing frustration, that he'd never make it as a practicing physician. "You don't connect with patients, Mr. Cole," Dr. Patricia Hernandez, his clinical skills instructor, had said during his second-year evaluation, her voice carrying that particular tone of disappointed concern. "Medicine requires empathy, effective communication, teamwork, essential skills that you, quite frankly, seem to lack. Have you considered pathology or perhaps radiology? Specialties where direct patient interaction is minimal. They hadn't understood, couldn't understand that Ethan felt everything too much, not too little. Every patient's pain resonated in his chest like a physical weight that made breathing difficult, their suffering echoing in his mind long after his shifts ended. Every diagnostic puzzle consumed him utterly and completely until he found the answer, his brain unable to disengage or think about anything else until the mystery was solved. Every life hanging in the balance became his entire universe, narrowing his focus to a laser point of concentration that excluded everything else: sleep, food, social niceties, his own well-being, but expressing those overwhelming feelings in ways that other people recognized as empathy, making the small talk that put patients at ease, navigating the countless unspoken social cues and contextual meanings that came naturally to neurotypical people. Those were the impossible challenges, the mountains he couldn't climb no matter how hard he tried. Now, standing in the trauma bay as Dr. Thornton dismissed his concerns with barely concealed contempt, while Marcus Whitfield's condition deteriorated minute by minute, Ethan felt the familiar frustration building in his chest like pressure in a sealed container. He knew he was right, with a certainty that transcended mere confidence and approached absolute conviction. He could see it in the constellation of symptoms, in the way the data points connected like stars, forming a recognizable pattern that told a clear and urgent story. The yellowing skin indicated hyperbilirubinemia, suggesting biliary obstruction or hepatocellular damage. The confusion and altered mental status pointed to hepatic encephalopathy from elevated ammonia levels as the failing liver couldn't process toxins. The abdominal distension suggested ascites from portal hypertension. The tremor in the hands was asterixis, the flapping tremor pathognomonic for hepatic encephalopathy. Every piece fit together into a picture of acute liver failure progressing toward multi-organ dysfunction. But knowing wasn't enough in the social hierarchy of medicine. He had to make them listen, had to overcome the barriers of his communication differences and his lower position in the medical pecking order. He had to translate his certainty into words that would penetrate Thornton's ego and institutional inertia. "Dr. Thornton," Ethan said, his voice carrying that flat, direct quality that people consistently mistook for arrogance or coldness, when it was simply the way his neurology processed speech without the automatic prosodic variations that neurotypical people employed unconsciously. Acute liver failure can progress to multi-organ failure within hours, not days. His mental status is already deteriorating. He was oriented ×3 when he arrived. Now he's confused about location and time. That's a rapid cognitive decline suggesting cerebral edema from accumulating toxins. We need to act now, not after labs come back. Every minute we delay increases his mortality risk exponentially. Thornton turned to face him fully, and Ethan saw the flash of anger in the older doctor's eyes, even though he couldn't quite interpret all the subtle facial micro-expressions that conveyed the full depth of Thornton's irritation and wounded pride. "Dr. Cole, I've been practicing emergency medicine for 23 years. I was treating liver failure when you were still in elementary school. I know how to identify hepatic insufficiency, and I know how to prioritize cases. What I see here is acute gastroenteritis, possibly viral in origin, with dehydration causing some mild confusion, and the jaundice likely from an underlying Gilbert syndrome, or perhaps medication-related cholestasis. We'll run the standard comprehensive metabolic panel, keep him hydrated with normal saline, give him antiemetics for the nausea, and reassess when we have concrete laboratory data instead of jumping to dramatic conclusions based on incomplete information." Marcus Whitfield, despite his increasingly compromised cognitive state, was paying attention with whatever mental resources remained available to him. His lawyer's mind, even dulled by accumulating ammonia and other neurotoxins, recognized a power struggle when he witnessed one, had seen countless such struggles play out in courtrooms, in depositions, in negotiations, and something in him, some deep instinct honed by 30 years of destroying opposing counsel and hostile witnesses on the stand, some visceral reaction to the younger doctor's odd mannerisms and different way of communicating made him choose a side in this conflict. "Get him away from me." Marcus Whitfield's words cut through the controlled chaos of the trauma bay like a gavel striking wood, like a verdict being read, like a sentence being pronounced. Everyone in the room froze mid-motion, conversations stopping mid-sentence, hands pausing in their task. Ethan felt every eye in the trauma bay turn toward him, felt the weight of a dozen gazes pressing against his skin like physical pressure, felt the sudden suffocating silence that followed Marcus's declaration. Marcus raised one trembling hand, the fine tremor of asterixis making his fingers flutter like dying moths, and pointed directly at Ethan with unmistakable intent. "That one, the weird one, the one who talks strange and moves strange. I don't want him near me. I don't want him touching me. I don't even want him in the same room." The words landed like physical blows, each one a small violence that Ethan absorbed with the practice of someone who'd endured similar assaults his entire life. He'd heard countless variations of this since childhood. Weird, strange, off, creepy, robotic, emotionless, cold, mechanical, broken. The labels people applied when they couldn't understand the way his mind worked, when his directness made them uncomfortable, when his lack of small talk and social pleasantries registered as rudeness or arrogance rather than simply a different neurological architecture, a different way of processing and interacting with the world. Dr. Thornton seized the moment with barely concealed satisfaction, his expression carefully arranged into professional concern, but his eyes betraying a hint of vindictive pleasure. "Of course, Mr. Whitfield, your comfort and confidence in your medical team is absolutely paramount. Dr. Cole, step out of the trauma bay immediately. That's a direct order." But even as Ethan moved toward the door with mechanical compliance, his hands clenching and unclenching at his sides as he tried to process the rejection and humiliation through the overwhelming sensory input of the bright lights and loud sounds and too many people in too small a space, his mind continued working the problem with relentless precision. Marcus Whitfield's pupils were definitely more asymmetric now than they had been 5 minutes ago, the difference between right and left pupil diameter increasing from 1 millimeter to nearly 2 millimeters, a concerning sign of increasing intracranial pressure, possibly from cerebral edema. The yellow discoloration of his skin had deepened visibly just in the minutes since his arrival, the icterus spreading and intensifying in a way that suggested rapidly rising bilirubin levels. Most concerning to Ethan's analytical mind, Marcus's respiratory rate had increased from 18 breaths per minute on arrival to 24 now, while simultaneously his level of alertness had decreased from confused but responsive to increasingly stuporous, classic signs of deteriorating hepatic function affecting his brain and potentially his respiratory drive as accumulated toxins poisoned his central nervous system. Ethan paused at the threshold of the trauma bay, his hand on the doorframe, knowing he was about to cross a professional line but unable to stop himself because a man's life hung in the balance. His ammonia levels, we need to check them immediately. Not when the routine labs come back, and he needs imaging now. A CT with contrast to look for hepatic vein thrombosis or biliary obstruction or space-occupying lesions. Waiting could be out now. Thornton's voice left absolutely no room for argument, carrying the full weight of his authority and position. "If you say one more word, Dr. Cole, I will have security escort you out and file a formal complaint with the residency program director. Do I make myself clear?" As Ethan stepped through the automatic door into the corridor, the door sliding shut behind him with a soft hiss that felt like a coffin closing, he heard Marcus Whitfield's increasingly slurred voice drift out. "Is that kid even a real doctor? He seems, I don't know, defective or something. Like there's something wrong with him. Shouldn't they screen for that?" The uncomfortable laughter that followed from one of the younger nurses felt like needles being driven into Ethan's ears. Each chuckle a small cruelty that accumulated into a larger wound. But worse than the social humiliation Worse than the professional dismissal, worse than being labelled as defective by a man whose life he was trying to save, was the certainty settling in his chest like a stone, heavy and cold and undeniable. Marcus Whitfield was dying, his liver failing catastrophically, and Ethan was the only person in this entire hospital who saw the trajectory clearly, who understood the urgency, who knew exactly what needed to be done, and he'd just been ordered to walk away and let it happen. Dr. Sarah Chen found Ethan in the supply closet on the second floor 20 minutes later, though to Ethan it felt like both seconds and hours had passed in that strange time dilation that happened when his mind was processing overwhelming emotions and sensory inputs simultaneously. The small room was dark except for the thin line of fluorescent light bleeding beneath the door, and Ethan sat on an overturned plastic bucket, his hands pressed flat against his thighs, with deliberate pressure, breathing in controlled counts of 4. Inhale for 4 seconds, hold for 4 seconds, exhale for 4 seconds, hold for 4 seconds, repeat. The technique had been taught to him by a therapist in college, one of the few coping mechanisms that actually helped when the world became too much, when the sensory input overwhelmed his processing capacity, when the social cruelty cut too deep. "I figured I'd find you here," Sarah said softly, her voice deliberately low and calm, because she'd learned over their 2 years working together that loud, unexpected sounds could be painful for Ethan, could feel like physical assaults on his nervous system. She didn't turn on the overhead light, didn't make him look at her face, didn't touch him without warning. All accommodations she'd learned to make naturally after months of working alongside him and actually paying attention to his needs rather than dismissing them. She was one of maybe 3 people in the entire hospital who understood that Ethan wasn't hiding from confrontation or sulking like a child. He was managing sensory overload, recalibrating his nervous system after the overwhelming cascade of social rejection and professional dismissal, literally regulating his autonomic nervous system through controlled breathing and deep pressure input. The labs came back on Marcus Whitfield, she continued, pulling out her tablet and adjusting the screen brightness down because she knew the blue light could be harsh on Ethan's light-sensitive eyes. "You were right. You were absolutely right about everything. His ammonia level is through the roof, 240 micrograms per deciliter, when normal is under 40. His liver enzymes are catastrophic beyond anything I've seen in 5 years of emergency medicine. AST over 4,000 when normal is under 40, ALT over 3,500, bilirubin climbing past 15 and continuing to rise, INR dangerously elevated at 3.8, meaning his blood won't clot properly. His liver is completely failing, Ethan. It's not gastroenteritis, it's not Gilbert's syndrome, it's exactly what you said, acute, fulminant, hepatic failure." Ethan's breathing steadied as his mind locked onto the data, the familiar comfort of numbers and patterns and objective measurements temporarily overriding the emotional turmoil of the previous 20 minutes. Numbers didn't reject him, patterns didn't call him defective, medical data didn't care about his social awkwardness or his flat affect or the way he couldn't make comfortable eye contact. "Did they order the CT scan?" he asked, his voice still carrying that flat quality, but steadier now, more focused. "What about hepatology consultation? Did anyone call for a transplant evaluation?" Sarah hesitated, and in that hesitation Ethan found his answer, even before she spoke. "Thornton's still treating it as acute hepatitis, probably viral. He's started lactulose to reduce ammonia levels and rifaximin to reduce ammonia-producing gut bacteria, which is appropriate management for hepatic encephalopathy, but that's not enough," Ethan interrupted, standing abruptly from the bucket, the decision crystallizing in his mind with the sudden clarity of a chemical solution reaching saturation point. "That's temporizing. That's treating the symptom without addressing the underlying cause. The progression is too rapid for viral hepatitis, way too rapid. Viral hepatitis takes days to weeks to progress to fulminant failure. This patient went from apparently asymptomatic to encephalopathic in less than 72 hours based on his history. There's something else causing this, an acute obstruction, maybe a tumor causing bile duct compression, possibly a vascular event like Budd-Chiari syndrome, with hepatic vein thrombosis, could even be drug-induced acute liver failure from acetaminophen or a prescription medication. Without proper imaging and a complete workup, they're missing the actual cause, and without identifying the cause, they can't implement definitive treatment. He'll continue to deteriorate, progress to cerebral edema, develop multi-organ failure, and die, probably within the next 4 to 6 hours. Sarah touched his arm gently, applying firm pressure rather than light touch, because she'd learned over time that deep pressure was calming to his nervous system, while light, unexpected touch could be distressing and activating. "Ethan, listen to me. He specifically asked for you to stay away. He said he didn't want you near him. Thornton has the case now, and he's the senior attending. You have to let this go. I know it's hard. I know you see what they're missing, but you don't have the authority to override an attending physician, and if you try, it'll be your career on the line, not his." But Ethan's dark eyes met hers with an intensity that made her breath catch, an intensity that people who didn't know him often mistook for anger, but that she recognized as absolute conviction, as moral certainty, as the moment when Ethan's analytical mind and his deeply buried but powerful emotions aligned in common purpose. "If I let this go, if I walk away and follow orders and stay in my lane and respect the hierarchy, Marcus Whitfield dies. Not might die, not probably dies, will die, with certainty approaching 100%. And I'll have let it happen because I was too afraid to challenge authority, too uncomfortable with conflict, too worried about my own career to fight for his life. I can live with him hating me. I can live with being called weird and defective and strange, but I can't live with letting someone die when I know how to save them." In the trauma bay, Marcus Whitfield's condition was deteriorating exactly as Ethan had predicted, with the inexorable progression of a natural law, as predictable and inevitable as gravity. The pain medication had provided temporary relief that allowed Marcus's blood pressure to stabilize briefly, but now the confusion that had been merely disorienting was giving way to something far more dangerous: altered consciousness bordering on stupor, his responses to verbal stimuli becoming increasingly delayed and inappropriate, his ability to maintain wakefulness slipping away minute by minute. "Mr. Whitfield, can you tell me where you are?" Dr. Thornton asked, his voice finally carrying a note of genuine concern beneath the practiced professionalism, the first crack in his confident facade appearing as the clinical picture refused to match his initial diagnosis. Marcus's response was incoherent mumbling, syllables strung together without semantic meaning, his eyes moving beneath closed lids in a way that suggested his brain was still trying to process information but failing to translate thought into speech. When his eyes did open in response to increasingly aggressive verbal and tactile stimuli, they seemed to look through rather than at the faces surrounding him, pupils dilated and asymmetric, gaze unfocused and wandering. One of the nurses, Jennifer, checked his vital signs with practiced efficiency, and her expression tightened with concern as she read the numbers on the monitor. Blood pressure dropping, 90/60, down from 120 over 80 15 minutes ago. Heart rate climbing to 120 from 90, showing tachycardia. Oxygen saturation down to 92% on room air, and his respiratory pattern is becoming irregular. Should I start supplemental oxygen? Thornton reviewed the lab results on his tablet for the third time, scrolling through the numbers as if repetition might make them tell a different story, his confident facade beginning to crack like a windshield under pressure. The numbers were worse than he'd expected, much worse than anything he'd seen in routine gastroenteritis or even severe acute hepatitis. "Start albumin infusion," he ordered, making clinical decisions on the fly as he tried to adjust his diagnosis to match the evolving clinical picture. "And get hepatology on the phone immediately. We might need to consider a transplant evaluation if this continues to progress. Also start broad-spectrum antibiotics in case there's an underlying infection triggering this decompensation." But even as he gave the orders with an attempt at his usual authoritative tone, some part of him knew with sinking certainty that they were behind the curve, that the patient's trajectory was steeper than their interventions, that something fundamental had been missed in the initial assessment. He thought briefly of Dr. Cole's insistence on checking ammonia levels immediately, on getting urgent imaging before waiting for routine labs, on treating this as a critical, time-sensitive emergency rather than a manageable case of acute hepatitis. Thornton pushed the thought away with the practiced ease of someone who'd spent decades avoiding self-doubt. He wasn't going to second-guess himself and undermine his own authority because some socially awkward resident with poor communication skills had gotten lucky with a clinical hunch. Except the numbers on the screen weren't supporting the luck hypothesis. They were supporting expertise and pattern recognition. The ammonia level of 240 was consistent with severe hepatic encephalopathy. The INR of 3.8 indicated critical coagulopathy, meaning any procedure carried massive bleeding risk. The rising creatinine suggested hepatorenal syndrome was developing as the failing liver poisoned the kidneys. Every data point screamed acute fulminant hepatic failure with multi-organ involvement. Suddenly, without warning, Marcus Whitfield's body convulsed violently, his back arched off the gurney in opisthotonus, his arms becoming rigid and extended, his legs stiff, his eyes rolling back until only the yellowed whites were visible, his jaw clenched so tightly that his teeth ground together audibly, foam appearing at the corners of his mouth. "He's seizing!" someone shouted, the words triggering immediate coordinated action from the trauma team. The trauma bay erupted into controlled chaos that was somehow both frantic and choreographed. Medications drawn from the crash cart with practiced speed, airways protected with head positioning and suctioning equipment ready, monitors screaming their alarms in a cacophony of electronic distress calls. Someone called out vital signs in staccato bursts. Saturation dropping to 85%, heart rate 140, blood pressure 70/40. Another voice. Push 4 milligrams lorazepam 4 now. Get the intubation kit ready in case we need to secure his airway. And, through it all, Thornton felt the cold finger of doubt tracing down his spine. Like ice water, the creeping realization that he'd made a catastrophic error in judgment, that his dismissal of the younger doctor's concerns had cost precious time, that his ego and institutional authority had blinded him to a clinical reality that should have been obvious. The seizure meant cerebral edema from accumulating toxins, meant increasing intracranial pressure, meant brain damage occurring in real time if they didn't reverse the underlying liver failure immediately. And Marcus Whitfield, the powerful attorney who dismissed Ethan Cole as defective, was now paying the price for that dismissal with his failing body and poisoned brain. Ethan stood outside the trauma bay doors, pressed against the wall in the corridor, where he wouldn't be immediately visible, but where he had a clear line of sight through the small observation window, watching through the reinforced glass as Marcus Whitfield seized. His entire body was rigid with the effort of remaining still, of not rushing through those doors, every fiber of his being screaming at him to intervene, to share what he'd figured out during his 20 minutes alone in the supply closet, processing the clinical data and differential diagnoses. His hands moved in, rapid patterns against his thighs, faster than usual, the stimming behavior intensifying with his emotional state. He'd spent that time in the dark supply closet doing what his brain did best, pattern matching against his encyclopedic memory of medical literature, running through diagnostic algorithms with computer-like precision, considering and eliminating possibilities until he'd arrived at the most likely diagnosis with high confidence. The seizure confirmed what he'd suspected: cerebral edema from hepatic encephalopathy, meaning toxins were accumulating to critical levels, meaning the liver wasn't just failing, it was shutting down completely. But the hospital's rigid hierarchy, the social rules that he struggled with but still understood existed and carried real consequences, held him in place like invisible chains. He knew that forcing his way into that trauma bay would likely end his career, would mark him as insubordinate and unable to work within a medical team, would confirm every negative evaluation he'd received about his inability to respect authority and follow institutional protocols. Then Dr. Elizabeth Monroe appeared beside him with the silent efficiency of someone who'd learned to move through hospitals without drawing unnecessary attention. As the hospital's chief of emergency medicine, She had the authority to override anyone in the department, including Thornton, and the institutional power to make decisions that wouldn't be questioned. She'd been reviewing the Marcus Whitfield case from her office after receiving an automated alert about the critical lab values following the deteriorating numbers, with increasing alarm and a growing suspicion that something was being missed in the clinical assessment. She'd also heard, through the staff grapevine, about the confrontation between Thornton and Cole, about the patient's request to have the autistic resident removed from his care, about the young doctor who'd predicted liver failure when the attending was treating gastroenteritis. "Dr. Cole," she said quietly, her voice pitched low, so their conversation wouldn't carry into the trauma bay where the team was still managing the seizure. "Tell me what you see. Give me your assessment without filtering, without worrying about hierarchy or politics. Pretend I'm a medical student and you're teaching me what's happening to Marcus Whitfield." Ethan didn't take his eyes off the window, didn't turn to face her, because maintaining observation of the patient felt critical even from this distance, but he answered with the clinical precision that came naturally when discussing medicine. "Fulminant hepatic failure with rapid progression. The seizure indicates severe cerebral edema from hepatic encephalopathy. His ammonia level is 240, which is neurotoxic. His liver isn't just failing, it's been acutely damaged or obstructed or poisoned. The pattern suggests acute on chronic disease, meaning there's likely an underlying chronic liver condition that's been asymptomatic or minimally symptomatic until a trigger event caused catastrophic acute decompensation. The speed of progression from apparently well to encephalopathic in under 72 hours suggests this isn't viral hepatitis. The differential includes Budd-Chiari syndrome from hepatic vein thrombosis causing acute congestion and liver death, acute biliary obstruction from choledocholithiasis or malignancy causing back pressure and hepatocellular necrosis, drug-induced acute liver failure from acetaminophen overdose or idiosyncratic drug reaction, or possibly a vascular event like hepatic artery thrombosis. Each has different treatments. We need imaging immediately to distinguish between them. Dr. Monroe studied his profile, watched the way his hands moved in those repetitive patterns, noted the flat affect that masked what she knew from experience was deep concern and commitment. She'd mentored Ethan through 2 difficult years of his residency, fighting constant battles with administrators who wanted to dismiss him as too different, too difficult, too unable to fit the mold of what a doctor should be according to outdated ideas about social performance and bedside manner. She'd seen past his awkwardness to the brilliant diagnostic mind underneath, had recognized that his supposed deficits in social communication were more than compensated by his extraordinary pattern recognition and clinical reasoning. She'd protected him from dismissal 3 times, had advocated for accommodations in his clinical rotations, had argued forcefully that medicine needed diverse minds and different ways of thinking. Now she had to decide whether to trust his judgment over that of her senior attending physician. "What's your working hypothesis for the underlying cause?" she asked, testing the depth of his analysis. "Budd-Chiari syndrome," Ethan said immediately, without hesitation, his confidence in his clinical reasoning absolute. "Hepatic vein thrombosis, causing acute liver congestion and failure. It would explain the rapid onset from the acute blockage, the severe elevation in liver enzymes from hepatocellular death due to blood backing up, the quick progression to encephalopathy from total loss of liver function, and the development of ascites from portal hypertension. If I'm right, he needs an immediate CT with contrast to confirm the diagnosis by visualizing the thrombosed veins, then urgent interventional radiology for hepatic vein stenting or thrombolysis to restore hepatic blood flow, and anticoagulation despite the bleeding risk. Without restoring flow, his liver will continue dying and he'll progress to multi-organ failure and death within hours. Dr. Monroe made her decision in less than a second, her decades of clinical experience telling her to trust the resident, who'd been right about everything, so far over the attending who'd been catastrophically wrong. She pushed through the trauma bay doors with Ethan following close behind, her entrance commanding immediate attention from everyone in the room. Dr. Thornton, her voice cut through the organized chaos like a scalpel, carrying the full weight of her authority. Stabilize that seizure with whatever you need, then get this patient to CT immediately. Full abdominal and pelvic CT with IV contrast. I want to see his hepatic vasculature in detail, and call interventional radiology. Tell them we might have a Budd-Chiari requiring emergency intervention. The CT scanner hummed with its characteristic mechanical rhythm as Marcus Whitfield's unconscious body, now intubated and sedated after the prolonged seizure, slid through the machine's circular aperture on the automated table. In the control room, separated from the scanner by leaded glass, Ethan stood beside Dr. James Park, the interventional radiologist who'd been called in from home for this emergency case. Ethan's eyes were fixed on the monitor with laser focus as images of Marcus's abdomen began to appear, slice by slice, each cross-sectional image revealing internal anatomy in grayscale detail. The images loaded sequentially, building a three-dimensional picture from two-dimensional slices, and Ethan's brain processed each one with the speed and precision of purpose-built software, pattern matching against thousands of CT images he'd memorized during his training. "There," Ethan said suddenly, pointing to a specific area on the screen with such certainty that both Dr. Park and Dr. Monroe leaned closer to examine what he'd spotted. The hepatic veins, all three major branches, right, middle, and left. Look at the enhancement pattern. They're completely thrombosed, no blood flow. The liver parenchyma shows heterogeneous enhancement consistent with congestion and necrosis. And look at this collateral vessel formation here and here, suggesting this might be more chronic than we thought, possibly acute thrombosis on top of chronic stenosis. Dr. Park, who'd been reading imaging studies for 25 years and had seen perhaps a dozen cases of Budd-Chiari in his entire career, felt a chill run down his spine as his trained eyes confirmed what the resident had spotted. Hepatic veins are completely thrombosed, massive congestion of the liver causing hepatomegaly. The parenchyma is dying in real time. And look at this. His finger traced a bright area on the scan showing abnormal tissue density. There's your underlying culprit. Large hepatocellular carcinoma, looks like about 8 centimeters, that we didn't know about. The tumor's been producing factors that increase coagulation, leading to the hypercoagulable state that caused the Budd-Chiari. This explains why it happened so suddenly. The cancer's been growing silently, probably for months or years, making his blood increasingly prone to clotting, till it finally formed a clot large enough to block the hepatic veins completely. Dr. Monroe stood with her arms crossed, watching the images scroll across the screen and feeling the weight of institutional responsibility settling on her shoulders. A patient was dying because her attending physician had dismissed the concerns of a resident, because social prejudice against neurodivergence had overridden clinical judgment, because hierarchy had been valued over expertise. "Can we save him?" she asked bluntly, needing to know the truth without medical euphemisms or false reassurance. Ethan's mind was already 3 steps ahead, his brain racing through intervention options, weighing risks against benefits, calculating probabilities and timing windows with near computational precision. Interventional radiology needs to perform urgent hepatic vein stenting to restore blood flow through the thrombosed veins. Simultaneously, we need to start anticoagulation therapy to prevent further clotting and to help dissolve existing clots, even though his INR is already elevated and bleeding risk is significant. We don't have a choice. Without blood flow, his liver continues dying. His only chance is if we can reduce the hepatic congestion enough to prevent complete organ failure and allow some hepatocyte regeneration. We'll need to manage his cerebral edema with mannitol and hyperventilation to reduce intracranial pressure. Even if we do everything perfectly, he'll need a formal transplant evaluation within days, and he'll need oncology involved for the hepatocellular carcinoma. His 5-year survival is going to depend on whether the cancer has metastasized. But first, We need to keep him alive for the next 24 hours, which is not guaranteed even with optimal intervention." The room fell silent, except for the CT scanner's mechanical sounds, the soft whir of the table motor, the hum of the X-ray tube rotating around Marcus's body. Everyone present understood the gravity of what Ethan had just articulated. They were looking at a best-case scenario that still involved months of treatment, a liver transplant, cancer therapy, and significant risk of death. The worst-case scenario was death on the table during the intervention or progressive multi-organ failure over the next hours despite their best efforts. Dr. Monroe turned to Dr. Thornton, who'd followed them, to radiology, and now stood in the doorway, his face pale as he stared at the screen showing the catastrophic pathology that had been developing while he'd been treating gastroenteritis. The look she gave him was cold and professional, but everyone in the room could read the subtext. There would be a reckoning for this, a detailed case review, possibly formal disciplinary action. "Dr. Thornton, call interventional radiology and tell them we have a critical Budd-Chiari requiring emergency intervention. Then notify the ICU that will need a bed prepared for post-procedure monitoring, and call hepatology for urgent consultation." Then she looked at Ethan with an expression that mixed respect, vindication, and something that might have been guilt for not intervening sooner. "Dr. Cole, you'll scrub in with the IR team. You made this diagnosis. You fought for this patient when no one else believed you, and you have the most complete understanding of his pathophysiology. This is your case now. See it through." For a moment, Ethan felt the weight of responsibility settle over him like a physical presence, heavy and profound. Marcus Whitfield, the man who'd called him weird and defective, who'd mocked his differences and demanded he be removed from his care, now had his life resting entirely in Ethan's hands. The irony wasn't lost on him, but it also didn't matter. Marcus Whitfield was a patient, a human being, a life hanging in the balance. And Ethan was a doctor. That was all that mattered. 3 hours later, Ethan stood in the intensive care unit watching monitors display Marcus Whitfield's slowly stabilizing vital signs with the cautious optimism of someone who understood how quickly critical patients could deteriorate despite apparent improvement. The interventional radiology procedure had been technically successful. 2 stents now held open the thrombosed hepatic veins, allowing blood to drain from the massively congested liver, reducing the back pressure that had been causing hepatocellular death. Blood flow had been restored, visible on the post-procedure imaging as contrast flowing through vessels that had been completely blocked an hour earlier. The organ was severely damaged. Large sections of dead or dying tissue that would take weeks or months to regenerate if regeneration was even possible, but it was functioning at a minimal level sufficient to sustain life. Marcus would need a liver transplant, would need months of treatment for the underlying hepatocellular carcinoma they discovered, would need management of his coagulopathy and hepatic encephalopathy and all the other sequelae of acute liver failure, but he would live long enough to receive that treatment. As Ethan reviewed the latest lab results on his tablet, ammonia levels beginning to trend downward, liver enzymes starting their slow decline from catastrophic heights, INR gradually improving with vitamin K administration, and fresh, frozen plasma transfusions, he heard a weak, hoarse voice from the bed. You're the weird one." Ethan turned slowly, his body language still carrying that characteristic stiffness that people found off-putting, but that was simply how his neurology manifested in physical movement. Marcus Whitfield's eyes were open for the first time since before the seizure, clearer now though still yellowed with jaundice, focused on him with an intensity that suggested his lawyer's mind was reassembling itself piece by piece as the neurotoxins cleared from his system. The endotracheal tube had been removed an hour ago after Marcus demonstrated adequate respiratory effort, leaving his voice raspy and damaged from the intubation. "I'm Dr. Cole," Ethan said simply, approaching the bedside with measured steps, his hands clasped behind his back to keep them from their stimming patterns. "Dr. Ethan Cole." I was one of the physicians in the emergency department when you arrived. Marcus's hand trembled as he raised it slightly from where it rested on the white hospital blanket, the fine tremor of weakness rather than asterixis now, his body depleted by hours of crisis and intervention. They told me, Dr. Monroe came by earlier and told me what happened, told me you figured it out, that you kept insisting something was seriously wrong when everyone else thought I just had a stomach bug, that you diagnosed Budd-Chiari syndrome and hepatocellular carcinoma before. The imaging even confirmed it, that his voice caught, emotion breaking through despite his weakened state, that I'd be dead right now if you'd listened to me and stayed away like I demanded, that you saved my life even after I mocked you, even after I called you defective. Ethan didn't know how to respond to gratitude, how to navigate the social script of this moment where emotional expression was expected but didn't come naturally to his neurology. He struggled with the appropriate facial expression, with the right tone of voice, with the expected reciprocal emotional response. So he defaulted to what he knew, what felt safe and honest, the clinical truth without embellishment. You have Budd-Chiari syndrome, secondary to an 8-centimeter hepatocellular carcinoma that was producing procoagulant factors leading to hypercoagulability and hepatic vein thrombosis. We've restored blood flow to your liver through interventional stenting, but you've sustained significant hepatocellular damage. You'll need formal hepatology and oncology consultations. You'll need to be evaluated for liver transplantation, though the presence of malignancy complicates that. You'll need staging studies to determine if the cancer has metastasized. The prognosis is guarded, but cautiously hopeful if the cancer is localized and we can get you to transplant before further decompensation occurs. Tears slid down Marcus Whitfield's yellowed cheeks, cutting tracks through the pallor of his skin. His voice, when he spoke, was thick with emotion that seemed to overwhelm his usual courtroom composure, that cracked through the armor of professional confidence he'd spent decades constructing. I called you defective. I mocked the way you talk, the way you move. I demanded you stay away from me because you made me uncomfortable, because you were different in ways I didn't understand and didn't want to understand. I judged you in seconds based on superficial characteristics, the same way I've judged countless people throughout my career, the same ruthless assessment I used to find weaknesses in witnesses and opposing counsel. And despite all that cruelty, despite my prejudice and my arrogance, you saved my life anyway. You fought for me when I'd rejected you. You diagnosed what was killing me when I'd called you defective. Ethan felt uncomfortable with the intensity of Marcus's emotion, with the weight of gratitude that felt unearned because he'd simply done what any doctor should do, treat the patient in front of him regardless of personal feelings. I'm a doctor. That's what doctors do. We treat patients, all patients, regardless of whether they like us or understand us or approve of us. Your opinions about me don't change my professional obligations or my ethical responsibilities. You needed help. I had the knowledge to provide that help. That's the entire transaction. But as he turned to leave, to escape the emotional intensity of the moment and return to the familiar comfort of lab values and medication orders, he heard Marcus's whispered words. No, that's what good people do. Good people who are better than those of us who judge and mock and dismiss based on differences we don't understand. Outside the ICU, Dr. Monroe found Ethan making detailed notes in Marcus Whitfield's electronic chart, documenting the entire clinical course with the precision and thoroughness that characterized all his work. Hell of a diagnosis, Dr. Cole. Textbook case of Budd-Chiari that probably occurs in less than 1 in a million people. How did you know? What made you so certain when you saw him for maybe 90 seconds in the emergency department? Ethan considered the question, tried to formulate an explanation for something that felt intuitive, that happened in his brain through processes he couldn't fully articulate. How did he explain that his mind saw patterns others missed, that his attention to details others dismissed as insignificant had caught the subtle signs, that his memory for medical literature allowed him to pattern match against rare diagnoses, that his supposed deficits in social cognition were balanced by extraordinary strengths in visual processing and systematic thinking. "I just saw what was there," he said quietly, inadequately, knowing the answer failed to capture the complexity of his cognitive processes. The constellation of symptoms formed a pattern. The pattern matched Budd-Chiari syndrome in my memory of case reports and medical literature. The hypothesis made predictions about what we'd find on imaging and labs. The predictions were confirmed. That's just how my brain works. I see patterns, I match patterns, I test hypotheses. It's not magical or special, it's just pattern recognition. Dr. Monroe smiled with an expression of satisfaction and vindication. "Then maybe it's time we start making sure everyone in this hospital sees what I see in you, Dr. Cole. Not the superficial things that make you different from the majority of doctors, not the social communication differences or the stimming behaviors or the flat effect, but the things that make you exceptional, the diagnostic brilliance, the encyclopedic medical knowledge, the pattern recognition abilities that border on superhuman, the absolute commitment to your patients regardless of how they treat you. You're going to be one of the finest diagnosticians this hospital has ever produced, and it's time everyone recognized that." As Ethan walked down the corridor toward the residents' lounge, his body exhausted from hours of sustained focus and emotional regulation, the fluorescent light still buzzed at that same overwhelming frequency that made his jaw tight. The hospital still hummed with too many sounds and smells and sensations that his nervous system processed with painful intensity. His social awkwardness hadn't magically disappeared. His communication differences hadn't resolved. The world was still overwhelming, still required constant effort to navigate, still felt like playing a game where everyone else knew the rules except him. But for the first time in a long time, maybe the first time since starting medical school, Ethan felt something shift inside his chest, a quiet certainty, a solid foundation, a core truth that couldn't be shaken by mockery or dismissal or being called defective. Being different, seeing differently, thinking differently, processing the world through a different neurological architecture, it wasn't a defect at all. It was exactly what had made him the doctor Marcus Whitfield needed in that critical moment. It was what had allowed him to see the pattern that others missed, to make the diagnosis that saved a life, to persist in the face of dismissal, because his conviction was based on clinical reasoning rather than social consensus. And tomorrow, when he walked back into the emergency department for another shift, there would be another patient, another diagnostic puzzle, another opportunity to use his unique cognitive strengths to see what others couldn't see. His differences weren't obstacles to overcome, they were tools that made him exceptional. And maybe, just maybe, that was finally enough. Thank you so much for watching this powerful and emotional story about Dr. Ethan Cole and Marcus Whitfield. This story reminds us that what makes someone different can also make them extraordinary, that the qualities society dismisses as weaknesses can actually be incredible strengths, and that true excellence means fighting for what's right, even when the world tells you to give up. If this story moved you, if it made you think differently about the doctors who might be treating you or your loved ones, if it touched your heart in any way, please hit that like button right now. Subscribe to our channel for more incredible medical stories that celebrate the diversity of human experience and the extraordinary capabilities of the human mind. Share this video with someone who needs to hear this message today. Maybe someone who's been told they're too different, too weird, too unusual to succeed. And drop a comment below. Have you ever been underestimated or dismissed because you were different? How did you prove them wrong? Let's create a community where everyone's unique. Strengths are celebrated, where being different is recognized as a gift rather than a defect. Thank you for being part of this community, and I'll see you in the next story.